Welcome to the deep dive. Today we're tackling severe rhabdomyolysis, which is, a really significant challenge in critical care.
It really is a big one.
We'll be dissecting a recent paper that looks into, well, a more intensive way to use CytoSorb, a therapy probably familiar to many of you listening. We've got a case series here that kind of hints at the potential benefits of running two CytoSorb filters in parallel.
Yeah, quite an interesting approach.
So our mission today is really to get to the core of this dual CytoSorb idea and figure out what it might actually offer us when managing these incredibly complex, often devastating cases.
Absolutely. Severe rhabdomyolysis is something we unfortunately see quite a bit, and its impact can be, well, profound.
Yeah.
Essentially, you're looking at a rapid breakdown of skeletal muscle tissue that leads to this massive release of intracellular stuff into the bloodstream.
Right, like what exactly?
Things like myoglobin, electrolytes, LDH, and crucially, creatine kinase CK. Now, we might see CK go up after, say, heavy exercise, but in severe rhabdo, the levels are just orders of magnitude higher. And the systemic consequences, they can be life-threatening.
And the big worry for us, certainly in the ICU, is acute kidney injury, AKI.
Exactly.
The numbers you see quoted are pretty sobering, right? Like 15 to 50% of these patients get AKI.
That's the range, yeah. It's a very common and serious complication. Several factors play into the risk.
Okay, like what?
Well, obviously, extensive muscle damage itself is a primary driver. Makes sense. Dehydration also makes things much, much worse.
Right.
And as this paper highlights, a CK level shooting above 15,000 UL, that's a strong signal for higher risk, both for the kidneys and just overall instability.
And it's the myoglobin specifically that's the main culprit for the kidneys.
It's particularly nephrotoxic, yes.
Okay, so let's unpack that kidney injury part a little. How exactly does myoglobin wreak havoc there?
It works through a few key mechanisms, really. First, myoglobin directly causes oxidative injury to the kidney tubules. It generates these reactive oxygen species.
Okay, like a corrosive effect almost.
Kind of, yeah, on those delicate structures. Second, the myoglobin molecules themselves can precipitate, clump together, and physically obstruct the tubules.
Like blocking a pipe.
Exactly, like a blockage in the system. And third, it can trigger renal vasoconstriction, which cuts down the vital blood flow to the kidneys themselves.
Wow, okay. A triple threat.
And what makes it even worse is that the systemic inflammation that often goes along with severe rhabdo, it can actually amplify all of these damaging processes. It creates this really challenging, vicious cycle.
So it's not just the myoglobin directly, but the body's own inflammatory reaction pouring gasoline on the fire.
Precisely.
That helps explain why our standard treatments sometimes just, well, fall short in these really severe cases. What are our usual go-to approaches and where do they hit a wall?
So initially, we're trying to mitigate the effects of all that released myoglobin and, stabilize the patient.
Makes sense.
This means aggressive IV fluids, sometimes adding osmotic diuretics like mannitol, basically trying to force a high urine output, flush things through.
Right, forced diuresis.
If AKI does develop and progresses to actual renal failure, then continuous renal replacement therapy, CRRT, becomes necessary. But here's a critical limitation. Standard hemodialysis membranes. They're just not very good at clearing myoglobin. Its molecular size is relatively large.
Too big for the standard filter pores.
Exactly. And that's where these other therapies, ones specifically designed for larger molecule removal, become really relevant.
Which leads us perfectly to CytoSorb. And this paper is looking at using it more intensively, suggesting it might be better at pulling out both myoglobin and those problematic cytokines.
That's the idea.
For anyone listening who might be less familiar, can you just briefly outline how CytoSorb actually works?
Certainly. CytoSorb is a hemoadsorption device. You integrate it into an extracorporeal blood circuit, like a dialysis circuit.
Okay.
The patient's blood flows through this cartridge filled with tiny, highly porous polymer beads.
Beads? Okay.
Yeah, these beads have a massive surface area, and they're designed to absorb, basically grab onto molecules up to about 55 kDi in size.
And that size range includes?
It includes both myoglobin and a pretty broad spectrum of those inflammatory cytokines we were just talking about.
Got it. And the standard use is what, replace it every 24 hours?
That's the typical manufacturer recommendation, yes. Replace the cartridge every 24 hours. And it has shown clinical benefit in, various critical care situations with lots of inflammation or hemodynamic instability.
But the authors here are raising a really key point in the most severe rhabdo cases, where you have this just overwhelming flood of myoglobin and cytokines. Maybe that standard 24-hour change isn't enough.
That's the core of their concern, yeah.
What's the worry there?
The primary concern is saturation, simple saturation of the absorptive capacity.
The beads fill up too fast.
Exactly. If the sheer volume of myoglobin and cytokines coming from the patient is just massive, it can exceed the binding capacity of that single CytoSorb cartridge well before the 24-hour mark. Once it's saturated, its effectiveness just plummets. So that's the rationale for looking into a more intensive approach, specifically using 2 CytoSorb cartridges at the same time, hooked up in parallel in the circuit.
Okay, running them in parallel. So you're essentially doubling the available adsorption surface area right from the get-go.
That's the concept.
Seems like a pretty logical step up if you're dealing with a massive load. What are the potential advantages they're hoping for with this dual setup in these really sick patients?
Well, the main goal is to significantly boost both the rate and the total capacity for removing these harmful substances.
Faster and more removal.
Right. The hope is that by rapidly knocking down the levels of myoglobin and inflammatory cytokines, you can interrupt that vicious cycle of kidney injury and systemic inflammation more effectively.
Okay.
This might potentially create a critical window of opportunity to actually limit the extent of organ damage.
Makes sense.
The researchers also hypothesized that using 2 cartridges in parallel might delay that saturation point compared to just one cartridge facing such an overwhelming load.
Right. Spread the load, last longer maybe.
Potentially, yes.
And to explore this idea, they present this case series just to give us a clearer picture. What kinds of patients were involved?
So this was a retrospective look at 3 patients. All had exceptionally severe rhabdomyolysis, but interestingly, from quite different underlying causes.
Okay.
One was a young patient with severe limb ischemia from a major embolism. Another had profound cardioseptic shock. And the third presented with an acute aortic dissection.
Wow, very different triggers.
Very different. But what linked them was the severity of the rhabdo. Initial CK levels were sky high, over 100,000 UL in 2 of the 3.
Okay, truly severe then. Let's dig into what they actually observed in these cases. What were the key findings?
So in the first case, the young woman with the aortobasiliac thrombosis, they used dual CytoSorb, but also with more frequent filter changes.
Well, how frequent?
They were replacing the cartridges every 8 to 12 hours. They did this over 4 days.
Okay, much shorter than the standard 24 hours.
Much shorter. And what was really striking was the very rapid drop in her CK levels. Went from over 100,000 down to 800 money by the end of that period.
That's a huge drop.
It is. They also saw improvements in her renal, hepatic, and cardiac biomarkers, but interestingly, despite that really aggressive clearance, she still developed AKI and needed CRRT.
Okay. So even with that intensive approach, it didn't completely prevent the kidney injury needing dialysis. What about case number 2, the patient with cardioseptic shock?
This patient got dual CytoSorb for 3 days, and then they switched to a single cartridge for a bit.
Okay.
Similar to the first case, they saw an effective reduction in both CK levels and inflammatory markers during that initial dual cartridge phase. Her kidney function stayed relatively stable, though she did need some intermittent CRRT.
Right.
Sadly, her overall condition just deteriorated because of the underlying severity of her myocarditis and sepsis. She ultimately died from multi-organ failure.
Yeah, that really highlights how rhabdo is often just one piece of a much bigger, more complex critical illness puzzle.
Absolutely. It rarely occurs in isolation in these severe scenarios.
And the third case, the man with the aortic dissection.
So with him, they used 2 dual CytoSorb cycles back-to-back, then followed up with 3 cycles using just a single cartridge.
Oh.
Again, they saw a rapid reduction in CK, consistent with the others. Importantly, they also noted a progressive decline in his liver enzymes, AST and ALT, and his cardiac marker, troponin.
That's positive.
Yes, and he achieved hemodynamic stabilization too. Now, like the others, he did develop AKI requiring CRRT.
Still needed CRRT.
Still needed it. But importantly, he ultimately recovered from his end organ dysfunction and the sepsis, and he was actually discharged successfully from the ICU.
That's a good outcome. So looking across these 3 quite different situations, the consistent theme seems to be a marked improvement in CK and inflammatory markers when they use the dual CytoSorb approach.
That seems to be the main signal, yes.
What does this suggest for how we might think about tackling severe rhabdo in our ICUs?
Well, I think this small series really underscores what a huge clinical challenge severe rhabdo is. It can pop up in all sorts of contexts, even in younger people without major prior health issues.
Right.
And when that muscle breakdown is massive, the risk of rapid, severe kidney injury is just really high. So while CRRT is and remains a cornerstone for treating established AKI,
Absolutely.
these findings sort of nudge us to think about more aggressively targeting the drivers of the process too, that huge release of myoglobin and the inflammation that follows.
And it seems CytoSorb, especially in this dual setup, gives us a more direct shot at those drivers compared to just standard renal replacement.
Precisely. The potential for faster, more substantial clearance of these mediators, that could be key to maybe preserving more kidney function and potentially improving overall outcomes down the line. The author's experience kind of hints at a possible shift towards more, let's say, preemptive or aggressive blood purification strategies alongside our usual RRT in these really extreme cases.
Because the standard single cartridge might just get overwhelmed too quickly.
That's their observation, yes. In situations with just an overwhelming toxin burden, a single CytoSorb might hit saturation too fast to provide the optimal benefit over that initial critical period.
So the dual setup is maybe a way to overcome that initial capacity problem, get more bang for your buck early on, and potentially sustain removal for longer.
That seems to be the idea they're exploring.
And crucially, like you said earlier, this isn't some brand new experimental tech.
Exactly. It's using the existing CytoSorb platform. It's technology that's already available, already familiar in many ICUs.
Right.
And their experience, limited as it is, suggests that this more intensive application using 2 cartridges is feasible and seems safe, even in these incredibly sick patients.
Okay, so for the critical care docs listening, let's try and nail down the practical side a bit more. Based on this initial experience, what can we actually infer about CytoSorb's removal capacity and its targets when you use it in this dual way?
Well, it's important to say the paper doesn't give us precise pharmacokinetic data. No graphs of removal rates per hour per cartridge for specific molecules.
Okay, no hard numbers on that.
No hard numbers. But the observed clinical effect is really the key indicator here. That rapid drop in CK levels across the cases, that's pretty striking.
And since CK is our main marker for muscle breakdown and myoglobin release.
Exactly. That rapid decline strongly suggests the dual setup does enhance myoglobin clearance quite significantly compared to what you might expect otherwise.
Okay.
And the other point is the frequency of cartridge replacement in that first case every 8 to 12 hours.
Yeah, that stood out.
It really implies that when you have a super high myoglobin load, you might need to swap out those cartridges much more frequently to maintain effective adsorption, even with 2 running.
So the dual setup helps, but might still saturate quickly in extreme cases, hence the frequent changes.
That seems plausible, yes. And it ties into their hypothesis about delayed saturation with the dual setup. Maybe it buys you more time, more sustained clearance over a period, compared to a single cartridge that might get saturated very, very quickly.
Okay, so summarizing that, we don't have exact removal rates from this paper, but the clinical markers, especially the fast CK drop, strongly point to more efficient and possibly more sustained removal with the dual cartridges.
That's a fair summary of the observations.
And the main targets we're aiming for are myoglobin, which is well within that sub-55 kilodata range CytoSorb handles, and those various inflammatory cytokines that fuel the fire systemically.
That's right. And we also saw those positive trends in other markers, didn't we? Creatinine, urea for kidney function, liver enzymes, AST, ALT, the cardiac marker troponin, and the inflammatory marker CRP. That suggests maybe a broader impact on the whole systemic mess beyond just myoglobin.
Of course, we have to be realistic. As the authors themselves point out, this is a very small case series. Limitations abound.
Absolutely. You can't draw firm conclusions from 3 cases. The findings are preliminary, definitely. And because it was retrospective, they couldn't collect really granular data.
Like what specifically?
Like specific cytokine levels before and after, inlet-outlet pressures across the filters to really measure extraction, or precisely quantified how much medication might have been cleared by the filter.
Right. Drug clearance is always a consideration with absorption therapies.
It is. And also, the fact that all 3 patients still needed CRRT, it hammers home that dual CytoSorb, at least in these instances, didn't completely prevent the need for kidney support.
Yeah, that's a crucial point.
So larger prospective studies are absolutely essential to really figure out its impact on preventing or maybe just lessening the severity of AKI in these patients.
And the authors also floated the idea, didn't they, that this kind of intensified hemoadsorption might have applications beyond Rhabdo.
They did. In other critical conditions where you see similar massive surges of inflammatory mediators or, products of cell breakdown, like tumor lysis syndrome, maybe severe sepsis or cytokine storm scenarios, even polytrauma.
Interesting. The underlying principle, rapidly removing a high burden of bad stuff, could potentially help in other acute situations.
It's a thought worth considering. They also briefly flagged the need to keep an eye on platelet counts, which can sometimes drop with CytoSorb, and also the potential interactions with drug dosing.
Standard precautions with extracorporeal circuits, really.
Pretty much, yes.
Okay, so to bring this deep dive towards a close for our listeners, especially those of you managing these critically ill patients day in, day out, this initial look at dual CytoSorb therapy presents, well, a promising idea. It's preliminary, yes, but it suggests a way to potentially manage severe rhabdo more aggressively.
Yeah, by enhancing the clearance of both myoglobin and those inflammatory mediators.
It suggests a possible strategy to kind of augment what we currently do, maybe address the underlying pathophysiology more directly.
Right, with the ultimate aim of preserving organ function better and hopefully improving outcomes for these incredibly sick individuals.
But, and it's a big but, as encouraging as these initial observations might look,
It's vital to stress this is early days. It's just 3 cases. We need much more robust research to really establish if it works, how well it works, and exactly how best to use this dual cartridge approach.
couldn't agree more. These initial findings definitely open up an interesting and potentially quite impactful path for future clinical investigation.
Indeed they do.
So on that note, here's a final thought for you, the listener. Thinking about how quickly extracorporeal therapies are advancing, how might we see even more intensified, maybe more personalized blood purification strategies evolve in the future, specifically to counteract devastating conditions like severe rhabdo? And what specific real-time monitoring tools or parameters could we actually use to guide those more aggressive therapies effectively? It's definitely a fascinating space to watch. Thanks for joining us for this deep dive.